Good evening, dear friends, dear colleagues. Welcome to our last ESGE webinars this year before Christmas. We have today a very interesting, topic about bowel cleansing. And I think for all of us, for gastroenterologists, a very important topic, how to prepare our patients for colonoscopy. And we have really great presenters, great speakers and experts in this field. And the next 60 minutes, I'm happy to chair this session with Professor Maria Pellise. She's head of the department at the University Hospital in Barcelona. Welcome, Maria. My name is Helmut Messmann. I'm the past president of ESGE. And our first speaker today is Professor Lorenzo Fuccio from Bologna. He's an outstanding expert in the field of endoscopy, and he's the committee chair of the research committee. And thanks to Lorenzo, who will start now his presentation with the topic optimal bowel preparation, the benefits and drawbacks in different administration protocols. So thank you, Lorenzo, for joining this evening with your presentation. And now I would like to start your presentation, Lorenzo.
First of all, I wish to thank you, ESG, for the kind invitation. This is, for me, a real pleasure to talk about bowel preparation, particularly about how to improve. In the next 20 minutes, we will try to understand how to improve the patient's experience with bowel preparation. These are my conflict of interest, which are relevant for this talk. So in the next 20-25 minutes, I will talk about the mistakes to avoid when we prepare our patient for colonoscopy in order to improve the patient's experience. The first mistake to avoid, the most importantly one, is to say to the patients to take all the bowel preparation at once, which means, in other words, to talk about the miraculous effect of splitting the dose, which means to split the dose in two parts. The first part, the evening before the colonoscopy, and the second part, the morning of the colonoscopy. Why it is so important to split the dose? We are really a lot of important items that I wish to address with you. First of all, it is very important because it increases the bowel cleansing rate. This has been clearly shown in several meta-analyses. This is one of the first published almost 10 years ago, in which it is crystal clear that if we split the dose of bowel preparation, the cleansing rate is significantly improved. And this is true regardless of the volume of the bowel preparation and the type of bowel preparation. However, if splitting the dose work only if we clearly say to the patients to start the last dose of the bowel preparation within 5 hours of colonoscopy and to complete at least 2 hours before the beginning of the procedure. Otherwise, the beneficial effect of splitting the dose is completely lost. Another important reason why we should invite our patient to split the dose is because if the patient split the dose of the bowel preparation, I become a better endoscopist. In other words, it increases my adenoma detection rate. This was clearly shown a few years ago by a seminal study by Franco Radelli and subsequently confirmed by several other randomized controlled trials. So it is very important to split the dose, but this was about the quality of bowel preparation. So let's talk why it is important to split the dose if I want to improve the patient's experience with bowel preparation. We have recently performed a study called the co-work study, in which we clearly show that if the patient split the dose, it reported the less impairment of working performance when compared with patients that took all the preparation the same day or the day before of the procedure. Furthermore, if the patient split the dose, it refers less sleep disturbance. This is very important. This very recent study showed that patients that split the dose has significantly fewer nocturnal awakening for bowel movements. But maybe the most important things to say to our patients and to reassure our patients is to say that if you split the dose, you will not experience more incontinence episode during the preparation and during your travel to the endoscopy suite. This is very important because these patients are very, very afraid about these side effects of splitting the dose in bowel preparation. Furthermore, if the patient splits the dose, the perception of the total volume intakes is significantly reduced. We perform during the pandemic a study in which we explore by the EndoPrem questionnaire, which is a validated questionnaire on the patient's experience for colonoscopy, several items. And this article has been just published in GATT in the current issue. And one of the items investigates the perception of the volume. And when the patient split the volume, the perception is significantly reduced. Another reason why we should split the dose is because it increased the tolerability of the preparation, and also the willingness to repeat it is significantly improved. So, did I persuade you? So, unfortunately, when we see the data, when we go into the detail of the data, we see that almost 1/3 of our patients still not continue to consider splitting the dose, but continue to take all the preparation the day before. And also, if you see this very recently published study in endoscopy, when you leave the patients the possibility to choose between splitting the dose and take the whole dose the day before, if the colonoscopy is scheduled in the early part of the morning, almost 3/4 of our patients will choose for the day before preparation. And also when the colonoscopy is scheduled later in the morning, then also in this case, 60% of the patients will choose the day before preparation. So, how can we improve the adoption of the split dose regime? I frankly believe that we should kindly but very firmly explain the beneficial effect of splitting the dose. And most importantly, it should be not an option. So it should be mandatory to split the dose. Furthermore, we have to reassure the patients and clearly explain that the experience with bowel preparation is significantly improved, and they will not experience any incontinence episode during the travel. They will not need to stop during the travel to the endoscopy suite. This is very important. So the information is the key to the adoption of splitting the dose. So the second mistake to avoid, to improve the patient's experience with bowel preparation is to tell to the patient that more is better. Now it is very well demonstrated that the low volume preparation are as effective as high volume preparation. And this is true when we consider the cleansing rate in the overall column and most important in the right column. But most importantly, when we invite our patient to assume a low volume preparation, the patient's experience is significantly improved as concern the compliance, the tolerability, and the willingness to repeat. So this is very important to suggest to assume a low volume preparation. In the same study that I cited before, in which we investigate the patient's experience with colonoscopy, we also understood that if we move to a more concentrated solution, we have to clearly tell to the patient, clearly explains, maybe the unpleasantness test is significantly increased when we move to a more concentrated solution. Indeed, overall, most of the preparation with 4 and 2 liter preparation, about 50% of our patients experience unpleasantness of the preparation, but it significantly increased up to 70% when we move to 1 liter bowel preparation. So, to the question of the patients, what volume of bowel preparation should I take? I usually answer that they should ask to themselves what kind of masochist you are. In other words, if you prefer to suffer more for less time, for a shorter period of time, or if you want to suffer less for a longer period of time. So the third mistake that I suggest to avoid is to starve your patients. So one of the most frequent questions that the patients ask us is, which is the diet that I should follow the day preceding the procedure? Now it is clear that between the low residual diet and the clear liquid diet, there is no differences according to the adequacy and the abdominal detection rate. However, we should have our patients to take a low residual diet because the side effects are significantly lower, and also the willingness to repeat it is significantly reduced. Therefore, just 1 day of low residual diet is what we should suggest to our patients. So the fourth mistake that we should avoid is to just say to the patient, just to read the instruction of the bowel preparation. This is very important to know because we now live with one smartphone in our hand. And now we well know that if you suggest the patients together with written information to have the so-called enhanced instruction, which means audiovisual aids or smartphone application, both the efficacy and the patient's experience is significantly increased. And this is much more true when we consider our target population, which are people older than 50 years old. This is very important to remember. In Italy, we have an experience with a cartoon. In this website, which the translation in English is I Teach You the Colonoscopy, we perform a cartoon in which children teach to the father and to the mother how to have an adequate bowel preparation and also have a very good experience with colonoscopy. This is a great success in Italy. Indeed, more than 1 million people have access to the site and have to the website have significantly improvement of their bowel preparation and experience with colonoscopy. So the last mistake that we should invite our patients to avoid is, and also we should avoid, is to consider all our patients equal, which means that if we consider the patient's experience, we know that at the moment that there are a subgroup of patients that have an increased risk of bowel preparation-related symptoms. Indeed, we perform a study in which we enroll more than 1,000 patients, in which we identify several factors. Indeed, not only the gender and the age of the patients, but also the mood of the patients, as well as the tendency to develop somatic symptoms may influence the experience and the development of symptoms related to the bowel preparation during the bowel preparation. Indeed, we also identify a phenotype. Indeed, if you are a woman with a bad mood and psychosomatic symptoms, and you compare with men with good mood without psychosomatic symptoms, the first group, the first phenotype have a more than 15 times increased risk of developing symptoms during the bowel preparation. This is very important because this means that there is a group of patients that deserve much more attention by our sides. Indeed, it's also important to inform this patient that if they develop their symptoms during the bowel preparation, they have an increased risk of developing symptoms even after colonoscopy. And this is very important to know because maybe these patients deserve much more of the addiction of oral simethicone to the bowel preparation. Indeed, as it suggests to add this oral simethicone, because not only it increases the efficacy and also the polyp detection rate, but also it significantly reduces the development of abdominal bloating during the preparation and soon after the colonoscopy. So how to improve the patient's experience with bowel preparation, my friends? First of all, it is very important to suggest to split the dose because it increases not only the efficacy of the bowel preparation, but significantly improves the patient's experience. But also, please remember what was used to say Ms. van der Roos more than 1 century ago, that less is more. So please, low volume preparation should be our gold standard for bowel preparation. It is very important to inform our patients because it increases the patient's experience, and also please consider to add visual aids and app, also maybe why not cartoon. Finally, don't starve your patient because now it's useless to have a long period of diet and not consider all patients that are made equal, but please consider that there are special class of patients that deserve much more attention by us. And thank you very much for your attention.
Thank you, Lorenzo, for this great presentation. I would like to ask our participants, if you have questions, please use Q&A, and we will discuss all 3 lectures at the end. So if you have now questions to Lorenzo's presentation, perhaps the next speaker will answer these questions that we discuss in a kind of round table. And now we come to our next lecture, Maria.
Yeah, I would like to introduce the next lecturer, which will be Miguel from Portugal. He's in Porto and in Coimbra, and he will talk about the management of patients at risk, effectiveness, safety, and strategies to address cases of suboptimal preparation. So, Miguel, please, the floor is yours.
Hi, Maria. Hi, Helmut. Hi, colleagues. So it is a pleasure to be here and to talk about this issue. So I will stress the management of patients at risk regarding effectiveness, safety, and strategies to address cases of suboptimal preparation. So some of the messages I will repeat from Lorenzo because they are really relevant to get what we need, which is an optimal preparation. So these are my, let's see if it works. So this is my conflicts of interest for this specific talk. And so what is the problem I mentioned of this issue? So we know that the rate of inadequate bowel prep might be as high as 35%. And it will imply for sure more difficult colonoscopy because you will need more time to clean. Eventually you get tired and you get less time just for inspection. You might lower your cecal intubation rate. If the patient is awake, he might have more pain and more bowel distension. If he's under sedation, probably you need more sedation. You will have your higher rate of complications. You will lower your adenoma detection rate. And even if you detect the polyp, you might have difficulties in the resection. And eventually you will even have to give up and schedule a new colonoscopy, which will increase costs, will increase your waiting list. And so the patient, you and your hospital will be dissatisfied. And so if you talk about quality in colonoscopy, if we fail this first one, which is the rate of adequate bowel preparation, it's easy to understand that we will jeopardize almost all of the other ones. So we need to get a bowel preparation if we want to think even in any issue about colonoscopy and quality. So we might prevent or we might have to deal with this. So most of my talk will be on how to prevent. So I think we need to try all the time to prevent an inadequate bowel prep, and eventually, if it happens, how to solve it. And so most issues on prevention will be repeating a little bit what Lorenzo already talked about. So we need to improve the adherence to the instructions. We need to improve the motivation to ingest all the bowel prep. And this goes with low dose, split dose, and timing. I think in 2023, we need to improve beyond the Boston score, and I will say what I mean with this. And then some cases of really difficult patients that eventually we need to change what we will call our standard bowel prep. And eventually, if it happens, how to solve it, and I will talk to it by the end. So to prevent a suboptimal preparation, we know that there are high risk factors for suboptimal preparation, patient-related factors and preparation-related factors. There are a lot of patient-related factors, and that's why it is so difficult to try to see every risk factor that our patient has, because they are related to age, to gender, to diseases, to medications, to inpatient, to obesity. So it's not easy to check for all of these things. Preparation-related factors are more easier to assess, and it should be a non-split preparation, non-compliance to instructions, as Lorenzo already told. If you gave more than 5 hours between finishing the preparation and starting of your colonoscopy, and probably the most obvious one and easiest one to assess is a previous history of bowel preparation. There are some scores that were assessed to use it in clinical practice, but they are not good enough. That's why ESGE does not recommend the clinical use of any of these models. So we had this experience in my department. So from outpatients that were referred from other departments to our department to make a colonoscopy many years ago, we added a nurse contact, And we saw that in 73% of cases, they tried to change the timetable for the bowel prep, mainly to try to stress patients to do the split dose. When we looked at the main outcome to be a good bowel preparation, we saw that if the patient really followed the indications, we managed to get a good bowel preparation in 90% of cases, which is the standard that we should look for, the threshold that we should look for. Because as Lorenzo already told, one thing is to propose a split dose. The other thing is people really doing in real life. And then we saw as a multivariate analysis for risk factors, failure to follow the nurse recommendations had a seven times more risk for failing to reach the good bowel prep. So first task is to improve the adherence to instructions. And the main thing is that we need to know that it's not just giving a written paper. So you should give written instructions, also verbal instructions, and at least some of them should be delivered by a healthcare professional, a doctor or a nurse, so they can assess the risk factors for inadequate prep or a previous case of inadequate prep. If we do this, what we would call enhanced instructions, we know that we have better cleaning results, we improve our cecal intubation rate, people are more willing to repeat, and although it was not statistically significant, we also detect more polyps. So it's not just one paper for people to read. We reached the same conclusion many years ago. We did this randomized study, so it was still before the split dose. It was a previous day 4-liter PEG, but if we had on oral and written instructions, personalized instructions from the nurse, we almost doubled the rate of our bowel prep preparation, but this was many years ago where the rate was really, really low. Second thing is to improve the patient motivation. And I will repeat some messages from Lorenzo. So we should go for low volume preparations. We have better compliance, better acceptance, similar rate of adverse events, and we have similar rates of adequate bowel prep. We need to split the regimen for every patient, and with this, the results will be better, and also the tolerance. And we need to aim for just 2 hours between the last intake and the hour of the exam. Regarding the low volume preparations, if we compare 2 liters PEG, which is the dark blue columns, with the 4 liters PEG, which is the light blue, we see that it's easier to take, people are more willing to repeat if needed, the compliance is the same, and the overall rate of adverse events, it's the same. So we don't need to have in every patient a 4-liter PEG, as we were telling like 10 or 15 years ago. If we split the regimen, for sure that we have, and Lorenzo also showed this, it's almost absolutely for every randomized study that we get better results in terms of 2.5 more rates of adequate bowel prep, and we can move from 33% to 85%. So again, we need to use the split dose and people to take the split dose to try to reach at least 90% as we aim to in our patients. And in this study we did also in my department, this was a randomized trial to see if instead of using just 1 day of diet, if we needed to use 3 days of diet for every patient. And we saw that in general, it was not needed. So 1 day diet, as Lorenzo said, it's enough. But the main risk factor for reaching an inadequate preparation in this randomized trial was if people was not adhering to the split dose. So again, one thing is to propose a split dose. Another thing is for people in real life to really do it. If they don't do it, the risk is 30 times more for not reaching an adequate bowel prep. And finally, Lorenzo already showed this slide. Again, we need to aim for the 2 hours, because in this study, which we had people with split dose and people with non-split dose, if the time is around 3 or 4 to 5 hours, split dose is better, and this is statistically significant. But if it's more than 5 hours, then you lose the effect. So if you put a split dose, but it takes more than 5 hours until the exam, then you lose the effect that you wanted with the split dose. So aim for the 2 hours. And in some places, in some departments, you should not go, you should think on practical difficulties that should not be overemphasized. So if you have any troubles with your anesthesiologist because they want more than 2 hours, we have at least 3 studies showing that we had a similar residual gastric volumes that are insignificant if you do a split dose. So there's no reason to say more than 2 hours regarding anesthesiology. What I mean with improving beyond the Boston score, I mean removing the bubbles. So in 2023, and the ESGE already had this recommendation, we need to use simethicone and we need to remove the bubbles. In every study that we have comparing use of simethicone without using the simethicone, we know that the rate of bubbles, it's around 40%. And it's not just the feces that give us trouble to see the mucosa, it's also the bubbles, and it takes time and it gets trouble to remove the bubbles from the colon. So we know from many randomized trials by now that we increase the adenoma detection rate, although we have a similar bowel prep quality, because if you know, for instance, if we use the Boston score does not take into account the bubbles. So the Boston score, it's the same with less bubbles, and you will see more. And for instance, when we did this study to try, excuse me, to try to, sorry, to validate and to have an evaluation study of evaluating a bubble score, what you want to see in real life is what you see in the left, that was classified as a 0 on this classification. You don't want for sure the picture in the middle, and for sure you don't want the picture as you have on the right. So this had a good inter-observer and inter-observer agreement. And when we use this scale in another randomized trial that we did, and we compared the use of 4-liter split dose PEG, and one of the groups did oral simethicone. So we saw that we managed to reach an adequate bowel prep that goes as high as 97%, which is almost perfect. But the bubble score, which 0, it's the better, we managed to have a 0 mean in the people that did the oral simethicone. And also another important thing was that we had a lower interprocedural use of simethicone of only 7%, while if you don't use simethicone in 37%, meaning 1 in every 3 patients, you need to add simethicone through your scope to remove the bubbles and have a good visibility. Regarding difficult patients, there are very few randomized controlled trials, but the ones that there exist are relevant to mention here. So if we have the previous inadequate prep, and this is a quite relevant risk factor for inadequate bowel prep, so you see there are only 2 studies that use split dose, but in both, the comparator is already an enhanced preparation dose. So this is not what we need to see in normal life. It's just say 1 day and no bisacodyl, but comparing 3 days of diet with bisacodyl. So if you compare 2 liters PEG with 4 liters PEG, 4 liters PEG split dose is better. If you go even further from 4 liters to 6 liters, 6 liters doesn't seem to be good enough, and you don't need to go further on this. But I will call the attention. So the comparator is not the standard preparation as we call it for in every day practice patient. Regarding inpatients, this is a very specific case of patients where the rate of inadequate prep goes as high as 34%. The message here is from the systematic review, a lot of randomized controlled trials, a lot of different things that were tested, is to do your best and do whatever you can do. Meaning that you can go from low volume to high volume solutions. You can go to educational interventions, and this means education to the staff, to the patients, or to the nurses. You can go to regimen modifications, and most of them are to splitting the dose. As always, we should split to get better results. And even what they call the miscellaneous methods. For instance, we have a study putting a nasogastric tube to put the patient who taking all the bowel prep. So whatever you have on hand, you should use it, and every measure will be good to try to have a better result. Regarding chronic constipation, which is another relevant risk factor, we have only 3 studies here. The comparator is what we would call a regular preparation, but they are all split dose regimens. If you increase the days of diet and use of bisacodyl, but you compare 4 liters PEG with 2 liters PEG, you don't find any difference. So attention, because we have more diet, bisacodyl, but it was not the same product. If we have the same product and if we have bisacodyl, so it seems that bisacodyl help us. while if you have the same split PEG regimen, lobiprostone was not efficacious on this kind of patients. So bisacodyl, yes, lobiprostone, no. Diabetic patients, which is the last group I want to talk to you about. So we have two very old studies using single dose PEG and not split dose. Lobiprostone again failed. And this study used magnesium citrate in both arms, which is not what we would call the standard dose today. And they doubled the dose of magnesium citrate. They found the result, but this is not what we should call a regular result. So these more recent studies, both with PEG split dose. Again, the comparator in these diet patients is a 3-day diet and not the regular 1-day diet. If you have the nurse support and medication adjustments, you get better results. But I need to make this comment. In my opinion, medication adjustments for a diabetic patient should be the normal and not your intervention. So this should be normal in every patient. And again, for 4 liters PEG split dose, bisacodyl was not helpful on diabetic patients. So you did your best to prevent, but what if you go to the colonoscopy and it's inadequate and you have to solve it on the moment? So we have 2 options. You can try to continue with the colonoscopy and you can use your irrigation pump during the colonoscopy. This is my personal experience. I will not use this, and I always try to repeat the procedure eventually the next day, but there's no clear evidence to support one or the other. I prefer to do a new preparation and have the patient again with a good bowel prep instead of trying to solve it. But if you want to reschedule, you have 2 options. You can try to reschedule the next day, or if it's not possible, on none the next day. If you do it the next day, we only have 2 studies, one with good results. So the rate of new failure dropped to 9%, but the other study was the same. So we don't have a conclusive data on this. We know that around half of the patients will comply if you propose to the next exam. You need to carefully assess what failed in the first day for not having the same failure on the next day. And probably the most relevant thing on this is the logistics aspects of your hospital, of your department. Because if you imagine that 1 in every 10 patients will not be good enough, so for every 10 patients you do one day, you would need to reschedule one of them for the next day, and the logistics might not be easier. If you will reschedule, but not on the next day, you can try to upgrade the volume to a high volume. You can add bisacodyl. You can increase the days of the diet, or you can do the 3 at the same time. And studies that use the 3 things on the same time, 3 days low diet, 10 milligrams of bisacodyl, and a high volume PEG, will reach a second good exam in 81 to 90% of cases. So in conclusion, to my take-home messages, first, we should do our best to prevent. And to prevent an inadequate prep, you need to improve the adherence to instructors. And so don't give just a paper. So talk, have some health professional doing it. The app has, Lorenzo told, some cartoons, whatever you can do it. Don't just give a paper for the patients to read. To improve the motivation, go for low volumes, every patient to split the dose, and try your best only 2 hours between the prep and the exam. And as Lorenzo told you, traveling should not be an issue, and you just need to address where you finish the preparation, how long will the patient travel to your department. You should go to remove the feces, but also to remove the bubbles. And for this, you need simethicone as a pre-medication or a prep with simethicone already there. And for difficult patients, you need to do your best. You need to do all the things that we are talking until now. Otherwise, you risk to have an inadequate prep. Even if it happens, I would go for an next-day colonoscopy, but you need to solve the logistics of the thing. Or if you cannot do it the next day, then there are some evidence to say that 3 days low fiber diet, 10 to 15 milligrams of bisacodyl, and 4 liter PEG on a split regimen will probably solve the issue. So thank you for your attention.
Thank you, Miguel, for this great presentation. I think more questions are coming in, but I think we will answer this question at the very end. And now we have our last presentation from Professor Laquiere from Marseille in France. He will give a lecture on clinical experience with PEG with citrate and simethicone bowel preparation for colonoscopy, observational and pivot studies. So Arthur, we are happy to have you here, and the floor is yours, please.
Hello everyone, it's my pleasure to present you clinical experiences with PEG with simethicone bowel preparation for colonoscopy. We talk about an observational French study and pivot studies. Okay, simethicone is a non-absorbable substance with very interesting physical and chemical properties. Indeed, oral simethicone is a substance that reduces the surface tension of gas bubbles and can dissolve the bubbles. As you know, simethicone commonly used as an oral agent to reduce bloating and its associated symptoms. And during colonoscopy, several factors can interfere with mucosal visibility in case of inadequate preparation. One of the most common is the presence of large number of bubbles. That's why studies and meta-analyses have assessed the effect of adding simethicone to a bowel preparation. Last 4 years, 5 meta-analyses have been published, and these 5 meta-analyses have assessed the efficacy and the safety of to adding simethicone in bowel preparation. In this first meta-analysis, compared the rate of high-quality bowel preparation assessed by Boston score. You can see that the odds ratio is better in group with simethicone than group without simethicone. Moreover, simethicone could increase adenoma and detection rate in subgroup analysis studies with low baseline of adenoma or polyp detection rates. In this second meta-analysis, the results are in agreement. The author conclude that simethicone with PEG regimen will be more helpful for adenoma detection rate, and simethicone with citrate with PEG will be helpful to increase cecal intubation. And the author shows that in addition, PEG ascorbic acid simethicone is the least likely to cause abdominal bloat. In this first meta-analysis published last 2 years, simethicone also improves the quality of bowel cleanness and improve polyp detection rate, but not adenoma detection rate. Simethicone, simethicone improves the detection rate of lesion in the right colon and decreases the abdominal bloating. But simethicone not as effect on vomiting and abdominal pain or cramping. These 2 last meta-analyses, simethicone improve colon cleanness also and improve adenoma detection rate. However, this improvement is not seen in patients receiving split dose PEG. Simethicone decreases abdominal bloating but has no effect on nausea and vomiting and abdominal pain. And the author concludes that simethicone be a useful bowel preparation adjunct in patients unable to receive split dose PEG. And in the last meta-analysis, the author concludes that the adjunction of oral simethicone significantly improves bowel preparation quality and may benefit adenoma detection in specific ceto low baseline adenoma detection rate. The results of these 5 meta-analyses were in agreement. Simethicone improves quality of bowel cleanness. Simethicone with PEG improves cecal intubation, improves detection rate of lesion in the right colon, improve polyp detection rate, and improve detection rate in specific setting with low baseline adenoma detection rate. And simethicone with PEG decrease abdominal bloating, but simethicone has no effect on nausea, vomiting, and abdominal pain or cramping. That's why the Chinese guidelines recommend strongly the use of oral simethicone in bowel preparation, but European guidelines not recommend but suggest adding oral simethicone to bowel preparation with weak recommendation, moderate quality evidence. Despite the result of these 5 meta-analyses, very few studies have assessed under real-life conditions the effect of supplemental simethicone in improving bowel preparation quality. Moreover, simethicone was added during or before taking the bowel preparation, and it is not included in bowel preparation. Furthermore, there are few clinical data on the ability of PEG with simethicone to reduce bubbles. That's why we conducted a study under real-life conditions, was to assess the efficacy and safety of a fixed preparation combining macrogol and low dose of simethicone. This observational French study is a prospective multi-center phase 4 study designed to assess in real-life conditions the efficacy and safety of oral solution XIMEPEG. Endoscopic were asked to assess the quality of the bowel preparation using the bubble scale and a Boston score, and they received training on the use of the 2 scale before taking part in the study. Cecal intubation, polyp detection rate, adenoma detection rate were collected. From February 2020 to May 2021, 101 patients were included in this real-life study. The presence of bubble was often non-existent. 19% patients having no bubbles, and when bubbles were observed, in all of cases, they did not interfere with colonic mucosal visibility. The mean overall score on the bubble scale was 0.1. The mean overall Boston score was 8.2, and cecal intubation was successful in 88% of patients. Concerning polyp detection rate and adenoma detection rate, polyp detection rate was 41% of patients, and in patients with a positive fit, polyp detection rate increased and was 60%. Adenoma detection rate was 36%, and in patients with positive fit, adenoma detection rate increased and was 42%. Adverse effects were infrequent. 65 patients reported no adverse effect, and preparation was taken in its entirety in 96% of cases, and when adverse effects occurred, they were mainly mild in intensity. In conclusion of this study, the study was this prospective multicenter phase 4 study evaluated the bowel preparation containing low dose combined with macrogol in real-life conditions. Over 95% of patients were without bubble. In addition, 95% of patients had score greater than 6, confirming the adequacy of the bowel preparation. The result of this real-life study confirms the benefits of adding simethicone to the bowel preparation, as previously demonstrated in a randomized trial. In patients undergoing colonoscopy in this study, polyp detection rate and adenoma detection rate were 52% and 56% respectively. This real-life study results were comparable to those reported in randomized studies and exceeded the European guidelines that recommend an adenoma detection rate greater than 25%. 65% of patients reported no gastrointestinal adverse effect, and totally bowel preparation was taken in 97% of cases. The adverse effects were reported were mostly mild in intensity. The results are comparable to those reported in the literature with 97% patient rate and tolerance rate. So, simethicone or not for bowel preparation? Probably yes, because simethicone seems to improve Boston score and decrease the bubble scale or bubble score. Concerning polyp detection rate and adenoma detection rate, the adjunct of simethicone in bowel preparation, polyp detection rate increase, and adenoma detection rate increase in specific setting in low baseline adenoma detection rate. Simethicone decrease abdominal bloating, but has no effect on vomiting, nausea, abdominal pain, or cramping. In conclusion, PEG with citrate and simethicone bowel preparation for colonoscopy is an excellent blend for cleaning colon in real life. Adding simethicone in colonic preparation reduces bubbles and increases bowel cavity cleanness. Polyp detection rate increase, adenoma detection rate increase in specific setting with low baseline detection adenoma and with an excellent tolerance. Thank you for your attention.
Thank you, Arthur, for this great presentation. And I think we have now time to discuss all three presentations.
Yeah, there are a lot of questions in the chat,
Yeah.
which is really fantastic. So if anyone wants to make more questions, please use it, because we will have this minutes to go through them.
I mean, we can start from the very beginning, one topic, and I think Miguel, you answered the question on difficult patients, those with chronic constipation. Maybe you can repeat your recommendations. The question is, patient with chronic constipation on regular laxatives, do you advise to continue up to the day before starting oral bowel prep, or do you recommend to extend the oral bowel prep for patients with chronic constipation? What is your advice?
So if you are sure that patient is on chronic constipation and is taking regular laxatives, they should continue to do it. And then there's some evidence that in these specific patients, you should increase your diet from 1 day to 3 days. So this is one of the few cases where if you have chronic constipation, you should increase the amount of the diet from 1 day to 3 days. So 1 day should be enough for almost every patient. But for chronic constipation, we have a few cases showing that using, and what is on the randomized control trial is use of bisacudyl. So they should keep on bisacudyl if they are doing it, and increase the days from 1 day to 3 days of diet, just for specific cases of chronic constipation.
And Miguel, I'm developing on that, but I suppose that we are talking on patients that are really on chronic constipation. I mean, not those patients that, because the percentage of people that have a Bristol, let's say, so
why I understand with this question is those patients that are already usually on laxatives, because if they stop it, they have like 2 or 3 or 4 days without any bowel movements. And so they know that they need, I think this is the question. So it's patient already on laxative. So it's not an occasional less of bowel movements.
And Miguel, also I wanted to comment, because it happens sometimes that those patients, very often they do a very rich fiber diet. So you ask them, and this is patients that they eat a lot of fiber. So I suppose that in those patients, in the ones that maybe the fact of telling them to change a little bit the diet earlier, because some patients explain you their diet and they eat fiber like all the time. So this is very exaggerated.
So but we need to stress them that for every day they need to do that fiber, but for the bowel prep, eventually they have to stop it for 3 days. But that's normal, so they don't be stressed because of it, but they will need it just for this specific patient. So as we showed in a study, so in the general population, it makes no sense to make 3 days of diet. This is clear. But for these specific patients, these are the only ones where we have not much, but some evidence that we should go for 3 days of low fiber diet.
Lorenzo, you showed in your presentation that the bowel preparation, the cleanness of the bowel correlates with the adenoma detection rate. So what is a well-prepared bowel? What kind of Boston bowel preparations is necessary? I mean, not everybody has 9. When should we repeat? But how is your strategy?
So this is a very important question. I frankly believe that we should consider that we are missing most of our lesion on the right part of the colon. So I think this is the crucial part. We have always to consider that a good and adequate preparation is a good preparation in the right colon, since if the right colon is adequately prepared, in almost all the cases, also the left part is adequately prepared. And also because we have a very different kind of lesion, as you know, between the left and the right part of the colon. So this is one reason why we should take care, most importantly, of the right part of the colon. So in my experience, it is very important to do the use of water exchange during the colonoscopy in order to further increase the Boston bowel preparation scale. And only if we have solid fascium inside the colon, then we can consider to repeat the colonoscopy. Otherwise, we have to do all the best that we can do, all our effort to improve the bowel preparation. This is very much important. So we have to take care when we have to take time for improve the bowel preparation.
Okay, thank you.
Lorenzo, there is a question in the chat that I think it's important to stress. When we talk about split dose, we are talking about morning colonoscopies. And when we have colonoscopies in the afternoon, should we also do some kind of a split dose? What is your advice? How would you advise to do that?
So this is a very good question. So generally speaking, if we are talking about low volume preparation, if we have an afternoon colonoscopy, we can do it in the same day, which means that it's preferable. It's always advisable to do it in a splitting fashion way. That it means that we can do the first part in the very early morning, and then have also a little pause between the two doses, in order also to reduce the risk of side effects such as nausea and vomit. This is very important to avoid, because this is what the patients very frequently refer to us, and that dramatically reduce the experience with bowel preparation. And then have always the rule that the patient should finish the second dose in the runway period between 2 and 5 hours, and possibly as close as possible to the beginning of the colonoscopy, but at least 2 hours before the start of the colonoscopy. This is very important to stress.
And in that same sense, another question is about this thing with anesthesia and the fasting that you have already commented on, but can you comment again? Have you ever had any problem by only giving 2 hours of fasting before propofol sedation? Does any of you have had any problem?
In my experience, sometimes there can be some resistance by some anesthesiologists, but you have to explain that it is very safe. We have almost also guideline provided by the same anesthesiologists that this is safe. So we should ensure and say that it's safe. There is no reason to concern.
Perfect.
One question maybe also to Arthur about difficult patients could be by patients with diabetes. So the question is how to manage patients taking GLP-1 analogs. What is your recommendation in this situation?
Okay, so if I understand the question, so at least for diabetic patients, there's no recommendation to change the conventional bowel preparation. So it's more relevant to stress the fasting. And so usually what we all try to do is for diabetic patients to schedule on the early morning. And that's why it's also relevant what Lorenzo already told, that even for early morning, we should stress to go for the split dose the same. Even if the patient has to wake up at 3 or 4 o'clock in the morning, and we need to stress how important it is to do the split preparation. And the second question is what I was telling on when I comment that randomized control trial. So we need to be very aware of the medication. So people need to know that when they start the bowel prep, they will not eat anymore. So they should stop all the medications for the diabetes. And especially for those that take insulin, it's very important to stress that they should bring their insulin to the department, because as soon as they finish the colonoscopy, awake or under sedation, they will do their first meal and the first shot of the insulin. But there's no recommendation, no randomized control trial saying that we should change the regular split preparation for these patients.
One question was also on obese patient. Are these also difficult patients who need a special bowel prep? Or
Now,
is
I
it
would
not
go
different?
again for the same thing. So there's no randomized trial saying that you need to improve the regular thing, but you need to be sure that you do all that is recommended. So people have to do a split dose, people have to do ingest all the volume of the prep. So everything that goes on the adherence, on drinking everything, on split dose, the water between the packages with the product. So everything is relevant for obese patients. But again, no need to do more than that.
Mhm.
And there is the question that I think that this is something that happens quite often and important with people with renal kidney problems in the dialysis, for example. What kind of bowel prep would you mostly recommend? How do you do? Because those patients are very often very ill, so also difficult to prepare, and they have these renal problems and the volume. What do you
Usually in general, so all PEG-based regimens are considered safe for dialysis patients, even if a high or low volume PEG, it's considered to be safe. And the second issue is that you should try to see where the patient, which days and hours the patient will do his dialysis session. So usually the best strategy is to make the colonoscopy in the morning and the patient will go in the afternoon to the dialysis department. And then again, do a split regimen for people to do the colonoscopy in the morning and then go to the dialysis. This would be the safest way to go.
And also, there's a question about mannitol, but can someone comment about mannitol? Because I think that there is some evidence that is not an adequate bowel prep. Can any of you have any experience or talk about the use of mannitol for bowel prep?
No experience from my side. No comment.
No, no experience at all. I know this is under investigation. Maybe in the future we will have some data. I think they have done some studies. Maybe it's not yet published, but I think at least in Italy there is something is going on. I don't know. Maybe in the future we will know much more about mannitol.
Okay. And any news from France on mannitol?
No,
No.
we have no experience of monitoring.
No experience in this round.
And then when there is someone that is really difficult to prepare, that people that go several times and they have done things properly, or people that don't want to have a laxative, what tips do you use? Do you have the patients in the hospital to get them ready? Do you put a tube? Do you do any of those things?
Okay, so now we are completely out of evidence. So I can say what is my personal experience from the last year. So those really, really difficult patients, so that came 1 and twice and 3 times, and it was always unprepared. So I think the first question is always to try to see if they follow the instructions as told. Because sometimes, especially when they come from the first time and it's failed, with a good talk, you find some things that were not as good as we told, and some instructions that were not as followed as we said. If you confirm that everything was okay, completely okay, then you should. The first attempt is like I told you. You should move to 3 days of low fiber diet, add bisacodyl, and go for a higher volume PEG, always on a split dose. And even if that fails, so now you get out of guidelines and out of evidence. In my personal experience, I have very, very few cases with this. And my strategy was, as an outpatient basis, to make 8 liters of PEG solution. And my advice, so that people would be able to do it, because it's not easy. So 4 liters, it's not easy. 8 liters would be tough. So I will go again. This is my personal experience. Very, very few cases and very, very few patients. My advice was to do the 4 liters in the previous day, during the day. So not in 4 hours, but during the day, they would drink 4 liters. And then I would do 4 liters on the day in the morning, and we'll schedule the colonoscopy in the afternoon. And again, as Lorenzo told, those 4 liters in the morning, try to do it as a split dose, so 2 liters very early, then people to stop a little bit, otherwise they will start vomiting, 2 liters by the end of the morning, and then schedule 2 hours afterwards. But again, personal experience, no evidence to suggest this. So this is very, very rare cases.
Okay, I think we are almost at the very end. Maybe a last question from my side. I mean, the take-home message is for our participants: split dose is a must. Less is more. Destroy bubbles. And instruct your patients. I mean, adherence to the instructions is very, very important. Not only giving them a piece of paper, but which patients need a special instruction. So is there a difference between men and women, old or young, or patients who had in the past a colonoscopy and they know about this examination, and those who never had one before? Maybe very short from everyone, a short answer, and then who wants to start? Miguel, you unmute. You can.
Yeah, okay. So I would stress that the main, so you already told the main messages, but then again, I think the main issue is that you need people to follow the instructions. As Lorenzo told you, more than 50% of patients in real life, they in fact will not do a split dose or follow the instructions as a whole. So we need to stress the relevance of the issue and why it is important to follow everything that we are saying.
Lorenzo?
Yeah, absolutely. I totally agree with your conclusion. I frankly believe that in the future, we should always include the enhanced distraction when we suggest the best bowel preparation for our patients. I also start thinking about tailored preparation for special cases. Now we are going to have enough data to a personalized preparation. So this is maybe the future, but we have to stress also in our current practice that not all the patients are equal, and we, in some cases, we deserve much more time to instruct correctly how to correctly, adequately prepare our patients.
Arthur, do you want to add something? Arthur?
Yes?
Do you want to add something? Or?
No, it's okay for me. It's
Okay.
perfect.
You agree? Okay.
I agree with you.
Yeah, we are right in time. Maria, I think we can close our wonderful webinar, the last one before Christmas. And yeah.
So thank you very much to Lorenzo, Miguel, and Arthur. I think you have gone through all the topics and been very clear with your messages. Thank you for the attendees and the questions in the chat. It's always very nice to have a lot of questions and for the discussion. And thank you to Alfasigma that has been our sponsors for this webinar. So thank you to Alfasigma as well. And now we just wanted to invite you to come to the next ESGE days in Germany, that we will celebrate the Jubilee, as you know, and also to renew, if you want, to your membership to ESGE. It's a good moment because it's the end of the year. And with all of it, we want just to tell you that Merry Christmas and a Happy New Year. And it was my pleasure to be here. So thank you very much and good night.
Thank
you, everybody.
Bye.
Have a nice Christmas time. Bye-bye. Happy New Year. Bye-bye.